Hello, hello.
Hello?
Okay. Echo, echo. Oh, sorry, this is. I'll just. I'm so sorry. I need that.
Jeffrey, I see you got a tour of our new ward. I see Brett gave you a tour of the new ward, did she? It's cool, right? It's really satisfying. Yeah. You going, Ron? Yeah. Ready?
Let's do it.
All right, we'll get going. Thank you, everyone. Thank you for taking the time. My name is Paxton Bach. I'm the program director for our fellowship here, and I'm very happy to introduce our speaker today for our What's New in Addiction Medicine rounds. This is today we're gonna be joined by Dr. Zacnicte May, who's one of our fellows. Dr. May completed her graduate studies in neuroscience before attending medical school at the U of A in Edmonton, followed by her residency training in family medicine at the University of Calgary, and moving to BC for fellowship training in addiction medicine through the BCCSU. She's going to be talking to us today about stimulant use disorder in pregnancy and postpartum. And it's such a really, I think, critical and topical subject. We all know, I think, all too well about the rising burden of stimulant use, about challenges in terms of management and treatment of stimulant use. And so talking about this in this very specific population, I think is hopefully a really great overview. This is just a really high yield subject, I think, for so many of us. So I'll turn it over to Dr. May for rounds, and I'll be back. We'll have the last 10 minutes or so for a quick Q&A once we're done. So with that, Dr. May.
Just lowering that down a little bit. So when I was growing up in Mexico, I never thought that one day I'd be at this like major hospital in Vancouver, Canada, giving a presentation. So truly, thank you all for being here today. Also, at some point, I will definitely hear the hospital speakers. And when that happens, I will just pause and restart when it's over. I'll be talking about stimulant use disorder in the peripartum population today. When I speak about stimulants, I'm going to be referring specifically to cocaine and crystal methamphetamine. So I won't be talking about MDMA or about substance use disorder with prescription stimulants. A special thanks to Dr. Bach and also Dr. Gascoigne, because they gave me invaluable feedback for this presentation. I would like to start with a land acknowledgement. The land from which I'm presenting here today are the traditional unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. No conflict of interest to declare. This is my outline here. We'll talk about prevalence, harms of using unregulated stimulants for mother and infant, breastfeeding, how stimulant use disorder in pregnancy is treated, emerging role for medications, and then some clinical pearls for practice. Objectives are in line with this outline, increasing our knowledge with a special lens on the peripartum population, how we would manage somebody who's pregnant and has a stimulant use disorder, talk about some of the evidence behind emerging role for medications, and then application to practice. Starting with prevalence, We'll first talk about stimulant use in Canadian females, not specifically in the prepartum group. What you're seeing here in this figure on the y-axis is that lifetime prevalence of methamphetamine use. And then on the x-axis, you're seeing the year. And so the lifetime prevalence for methamphetamine use in Canadian females is just over 2%. To mention that this is likely an underrepresentation because not everybody may feel comfortable disclosing this information. And also the population that we serve that's very vulnerable may not be answering these surveys. So now this next graph is looking at stimulant use for individuals accessing harm reduction services in British Columbia. So similarly, on the y-axis, we have the percentage, on the x-axis, we have the year. And what we're seeing is increasing numbers of people have crystal methamphetamine as a substance they've used in the last 7 days. Unfortunately, we don't have a lot of Canadian data in pregnancy and like substance use. So this is data from the United States. And this highlights two things. One, that prevalence is relatively low, but also that there's likely a lot of regional variance. If we look at A, we see the adjusted prevalence on the y-axis, and then we have the year on the x-axis. And you see that through the years, we have increasing prevalence of cocaine use. But still, it's under 1%. And then in B, with methamphetamine, same axis, and we see relatively stable prevalence for methamphetamine use. This is for all individuals who were accessing prenatal care in Northern California. And all of these individuals were insured. So again, likely an underrepresentation because the vulnerable population that we serve may not have insurance. This study, Turpin et al., I think is very interesting. They looked at individuals accessing treatment services for substance use disorders. And what they found is that pregnant women were actually more likely to have crystal methamphetamine as their primary substance. If you look at the table there, for men, it was 6.9% that had meth as the primary substance. Non-pregnant women, it was 12.4%, but then pregnant women was almost 24%. Also, these numbers were increasing through the years. As to why this is the case, I think that there's multiple possible explanations. One consideration is that there's a relationship between risky sexual behavior and unregulated stimulant use, which may explain why there was this larger group that was pregnant. Next, to touch on that prevalence throughout pregnancy, it decreases over the course of pregnancy. So again, US data, and we see that from the first to the third trimester, the prevalence percentage goes down, and that's also the case for the frequency and the amount that's used. However, even at the end of all of that, there's still about 29% of them that continued with high use. So for the take-home points, the prevalence is low, but although this is the case, we're still seeing rising rates of unregulated stimulant use in the reproductive age population. And it is one of the primary substances used by pregnant persons. The prevalence decreases over the course of pregnancy, but there's still a significant percentage that still are using quite regularly. Onto associated harms. We'll talk first about just like general harms, not specific to postpartum, and then we'll go into specific harms for mother and infant. As we're all aware, we're in the midst of a drug toxicity crisis. In this figure from the BC Coroner Service, we see that fentanyl is the drug that's most commonly associated in drug toxicity deaths, but this is followed by cocaine and methamphetamine. And if we look at any stimulant involvement, that percentage is over 70%. There's a lot going on with this graph, but it's making the point that drug toxicity is a leading cause of death. If we look on the y-axis, these are different causes of death, both accidental and non-accidental. Then on the x-axis, we see the percentage. And then in the first column, we see the percentage of total potential years of life lost. Illicit drug toxicity is only second to malignant cancers in terms of potential years of life lost. And in the second column, we see that in terms of total deaths in British Columbia from any cause, illicit drug toxicity is number 4. That means that more people are passing in British Columbia from drug toxicity than they are from stroke, from diabetes, from COVID-19, from suicide. Not only that, but stimulants are putting increasing pressure on our healthcare system. So this is the number of emergency department visits involving an amphetamine, with a focus on regulated amphetamines in Ontario. And you can see here y-axis number of visits, x-axis the year, that through the years, we're seeing increasing numbers of visits. Then in B, we see the same data per 100,000 Ontarians, but it's split by sex. And although males are presenting more often with these concerns, females are following a similar curve with increasing presentations. Now here in C, same data, but now we're looking at it as split by age group. And the point I'm trying to make here is that it is our younger age group, like reproductive age cohort, that's showing the steepest curves. In D, it's similar data, it's just like per 100,000 Ontarians. On to maternal harms. And now I want to clarify that what you're seeing here is a snapshot picture. It doesn't include every harm that's ever been described, but it's what I found most commonly reported in the literature. For methamphetamine, its use is associated with increased levels of maternal psychiatric illness, decreased rates of breastfeeding, increased referral to child protective services, as well as dental disease. For cocaine, it's associated with maternal demise. It's also associated with end organ effects. And both have been linked to high blood pressure, heart attack, and blood-borne illness. And just to note that a lot of this data hasn't properly controlled for covariates like poverty and malnutrition and stress. Now for fetal harms. So for methamphetamine, it's been linked to intrauterine growth restriction and also fetal loss or miscarriage. And cocaine has been specifically linked to preeclampsia, placental abruption, and also vertical transmission. Both have been possibly linked to birth defects, but for these studies in particular, there wasn't proper control for covariates. Both have been linked to a smaller size, birth weight, length, and head circumference, as well as prematurity, and a withdrawal syndrome at birth with high-pitched cry, tremor, abnormal tonicity. For our take-home point here is that stimulants are commonly involved in drug toxicity deaths, which is a leading cause of death in British Columbia. We're having more pressures in our healthcare system from unregulated stimulant use. And unregulated stimulant use is associated with numerous maternal and fetal harms. But of course, this should be interpreted with caution because of all the covariates. Breastfeeding. Both methamphetamine and cocaine are transferred into breast milk. And now for methamphetamine, it's detectable in breast milk for up to 100 hours, with an average being closer to about 72 hours. And with cocaine, is detectable for up to 36 hours, an average 24 hours or less. The reason why infants are highly sensitive is because, so cocaine is metabolized via numerous pathways, but one of them involves cholinesterase, which infants do not have. So they are not able to properly metabolize it. And again, just wanted to point out the caveat for these studies that usually it's only like very few individuals. Effects on breastfed infants for methamphetamine. There's queer association with infant mortality after being exposed to the breast milk. These pathologists in Australia, they did analysis on postmortem samples from infants that had passed at less than 1 year. And they found crystal methamphetamine there. However, their N was 7. And also, like 3 of them had co-sleeping, 1 of them had pneumonia. So it's correlational data. Then with cocaine, there's multiple case reports that have been documented with some severe outcomes like seizures. Both methamphetamine and cocaine suppress prolactin, which of course is important for mammary gland development and milk production. It's unclear what the clinical significance of this is and whether it's related to the lower rates of breastfeeding that are seen. One thing I'd really like to emphasize is that breast milk is liquid gold. It has so many benefits for mother, infant, and society. For the mother, it decreases the rates of different kinds of cancers as well as diabetes. For the infant, you see decreased risk of sudden infant death syndrome, decreased rates of colitis, of Crohn's disease, diabetes, leukemia, obesity, asthma, eczema, otitis media, meningitis. It's quite remarkable. And for society, of course, decreased healthcare costs, not having to cover the cost of formula or donor milk, and just improved health for the population. So if somebody is using crystal methamphetamine or cocaine, it doesn't mean that they cannot breastfeed. It should be a risk-benefit assessment. And perinatal addiction medicine experts, some of them have recommended delaying breastfeeding by 100 hours after last use of the unregulated stimulant. That is 4 days, which is a long time. And some women may never initiate breastfeeding if they have to wait for that long. So some other experts have suggested that breastfeeding could be initiated sooner. For example, with cocaine, because it's cleared so much more quickly from the breast milk. So nevertheless, a note of caution with this, because there can be cross-contamination between the stimulants, and that will also apply to other substances as well. A stimulant supply, although rarely, is contaminated with fentanyl. And that's something to consider. So this is a situation where urine drug testing may be helpful in guiding when to initiate breastfeeding. However, that needs to be a very individualized case-by-case basis, because the mothers may feel such tests as very, very stigmatizing. So it really depends on the person, how motivated they are to breastfeed, what their goals are. So take-home points. Stimulants transfer into breast milk, and they have been linked to really severe outcomes. But this is based primarily case report data. Breastfeeding is associated with numerous benefits for everybody. Stimulant use is not a contraindication to breastfeeding. Some experts recommend delaying by 100 hours after last use. Now, how do we manage stimulant use disorder? Let's start by talking about how we manage it in the general population. I got this from UpToDate. Now, if the stimulant use disorder is mild, then counseling. If it's more than mild or counseling doesn't work, then you go on to contingency management, which is simply a form of treatment where rewards are provided for the person not using stimulants. If that doesn't work, then you go on to medications. So as you can see, medications are sort of at the bottom of the treatment algorithm. And now what medication to use is based on clinical trial data. So for cocaine, usually the medications that have been recommended are topiramate or a long-acting amphetamine or both. And then for not cocaine use disorder, then would be bupropion, naltrexone, mirtazapine, methylphenidate. If we look at the recommendations in pregnancy, so first of all, comprehensive prenatal care. Because a lot of individuals who are pregnant and using substances have faced such stigma through their lives and probably have a lot of negative experiences with the healthcare system, they may not present to care until they are in labor. And that often does happen. And as such, they may not have had any of the prenatal workup, none of the blood work, none of the ultrasounds. And though first and foremost, it's important that we do those standard labs to optimize health. Then, in terms of interventions, psychosocial treatment is a first line. So we have contingency management, family education, different kinds of counseling, not just CBT, and then 12-step programming. I will go over the evidence for each of these in a moment. First, I just wanted to explain what I mean by comprehensive prenatal care. So now, because this is such a vulnerable population, they may be experiencing food insecurity and poverty. And so allied health involvement is critical with dietitian and social work. All that blood work with STBBI screening, GBS, gestational diabetes, checking for RH status and giving ROGAM if indicated. Because of the association with intrauterine growth restriction, then more ultrasounds are recommended. For instance, not just one at baseline, but then one in the third trimester. And I've spoken to some addiction medicine experts with a perinatal background, and they actually will do an ultrasound like at each trimester. Non-stress test and intermittent auscultation as clinically indicated, and lots of support after delivery. Let's start with contingency management. So like I said before, the rewards are going to be usually monetary vouchers, but sometimes gift cards. And I was reading about this one really cool contingency management program for pregnant persons. And what they were giving us rewards were like little onesies and little coloring books and like pacifiers, which I thought was really adorable and so relevant. There have been multiple clinical trials showing benefit. The one that I consider to be the best will go into a little bit more deeply. Two of the clinical trials I'm citing were for cocaine and or opiates, which is why I don't delve into them as much. And then one of them was just very small, a very small randomized clinical trial. For family education, so there's this one study that I thought was interesting. It's kind of like a prospective cohort study. And what they did is they introduced this family reintegration approach where with the consent of the mother, they would try to help them become reconnected with family members. And they found that by doing this, there was increased retention as well as decreased use of cocaine. There's also this randomized control trial. This one was for cocaine and or opiates, where a nurse would go to the patient's home and then provide feedback on like parenting skills and emotional support. And they found that this led to actually decreased behavioral issues in the child later on. as well as decreased stress of the parent. So for counseling, in general, it doesn't seem to really matter what kind of counseling it is. So there's this one like randomized trial where they were comparing either CBT with motivational enhancement therapy, not contingency management, just kind of like motivational interviewing. And they were comparing that to brief, like 1 minute counseling by the obstetrician, and both seemed to be beneficial. There wasn't like one that was better than the other. And unfortunately, there was a rebound effect afterwards. So after the counseling was stopped, then there was increase in substance use. Then lastly, for 12-step programming, I didn't find a lot of evidence like for stimulant use disorder in this population. And referring to like a higher power, nowadays, it's not necessarily like a religious higher power. It depends on the person and what they consider to be a higher power. Having a peer sponsor and also rectification of past mistakes. But I've seen it described as a component of more comprehensive treatment programs. Diving into that continuity management randomized study that I was talking about, they had 145 participants and they were randomized to 4 groups. So one was contingency management for plus community reinforcement. And this was very similar to CBT. It's a form of talk therapy. And it was focusing on goal setting and sort of trying to identify new reinforcers in the community that were not stimulants, as well as kind of like a skill development to try to achieve those goals. Then they had continuity management plus 12-step facilitation, which is like what I described before. And they had 2 voucher control groups where the individuals were getting monetary vouchers, but it was not contingent on having negative urine drug test. The outcomes were abstinence-based, as you can see here. And what they found is that contingency management was associated with longer duration of abstinence, more negative urine tests. However, it didn't seem to matter whether this was paired with CRA or with TSF. So it didn't matter if it was community reinforcement or the 12-step. So for my take-home points, standard of care for stimulant use disorder in pregnancy would be comprehensive prenatal care and primarily contingency management. We do need more rigorous data for other interventions. Emerging role of medications. I would like to preface this by saying that we virtually have no data in the peripartum population. I will speak to when there is something that's relevant to like reproductive age women or a case report. I'll make sure to highlight that. Okay, starting with bupropion naltrexone. So there's this randomized controlled trial that was recently done, and then they did a secondary analysis of it, and they showed that this combination of medications was beneficial in reducing methamphetamine use. And they said that 90% were capable of pregnancy. I'm not sure what they meant by this exactly. I don't know if they meant like they were like reproductive age or if they had asked them about their reproductive health. Now, what considerations would we have in pregnancy? So now with bupropion, it's been prescribed so much for smoking cessation and mental health. And so we do have a lot of data. This systematic review was looking at 3 studies did not show any cardiovascular defect, but then 3 studies did show that. And then with naltrexone, so naltrexone, as you all know, it's a mu opioid receptor antagonist. And so this can make pain management really challenging, especially somebody who, like is going into labor, may need special analgesic care. And then also, in order to initiate naltrexone, if the person also has an opioid use disorder, then not being on opioid agonist therapy and going on this, they would have a loss of tolerance and potentially greatly increase the risk of overdose. So now here, I am talking about pregnancy categories for these medications. Now, I didn't include the FDA categories because those are being phased out. So you can't actually find FDA categories for most of these medications anymore. However, the Australian categories are very similar to what the FDA categories used to be. First, with bupropion, it's a B2, which means that it's been given to a small group of pregnant individuals without fetal harms being seen, and there's no animal studies that have shown harms. For naltrexone, it means, again, small numbers of individuals have received the medication without evidence of fetal harm. But it's B3, which means that there's maybe an animal study out there that has shown harm. For medical amphetamines, so there's some evidence for promoting abstinence in cocaine use disorder. This is for the general population. And I did find a case report in pregnancy where they found lisdexamfetamine was beneficial in helping somebody achieve abstinence. For pregnancy considerations, on systematic review of the ADHD literature, there's been no adverse effect seen. But just to mention that the dosages for medical amphetamines, in order for those to be beneficial for stimulant use disorder, they are typically higher than those used in ADHD. Whether or not the prepartum population would need such high doses, we don't know. Dextroamphetamine and lisdexamfetamine are both B3. Mirtazapine. So with mirtazapine, we've seen a benefit in reducing meth use, but this is specifically in men and transgender women, so not in our population of interest. It is considered to be safe in pregnancy. It's category B3. Methylphenidate has also been shown to be beneficial for decreasing meth use. However, there have been different defects and also like placental issues that have been documented. And so it's pregnancy category D. Pregnancy category D, meaning that the drug is suspected to have caused fetal harm in humans. Then we have modafinil, which is beneficial for cocaine use disorder, but also associated with some birth defects. So it's pregnancy category D. And then topiramate, again, beneficial for cocaine use disorder, but they have found increased rates of oral cleft, pregnancy category D. And just to mention too, though, that with pregnancy category D, it doesn't mean that it's impossible to use that medication. That benefits may still outweigh the risks, but the risks are something that should be considered like a lot more. So now let's briefly talk about the ADAPT-2 trial. This is the one that was looking at naltrexone and bupropion. First, I'll talk about the trial itself, and then we'll get into the secondary analysis. So now this trial included over 400 individuals with methamphetamine use disorder. It was double-blind and placebo-controlled. The participants were randomized into two different groups, one which received intramuscular naltrexone and also oral bupropion, and the other which got placebo. And then from the placebo group, those individuals who did not benefit, aka non-responders, were then randomized into an experimental group and a control group in a second stage. And the only reason why I talk about the stages is because their outcomes were sort of based on the stages. For the secondary analysis, they looked at 126 women, methamphetamine use disorders. So the outcomes were treatment response was if they had 3 negative urine drug tests out of 4 in the last 2 weeks of each stage, and treatment effect was the difference between the treatment responses of each stage. So again, the initial group was randomized into experimental and control groups, and then the non-responders in the control group were again randomized. And what they found is that there was a greater treatment response with naltrexone and bupropion compared to when placebo was given. So in other words, naltrexone and bupropion was helpful in reducing crystal methamphetamine use. And then I just wanted to touch briefly on this case report. So this is where they gave lisdexamfetamine for somebody with methamphetamine use disorder who was pregnant at the time of the study. And they found that this helped the individual stop using crystal methamphetamine. The contingency management component of the study was that they would give the person carries of that lisdexamfetamine when they had negative urine drug tests. So what that just means is that the individual was able to take home more doses of the lisdexamfetamine for having the negative urine test. Now, whether the benefit was because of this contingency management component, whether it was the medication itself, or whether it was just being more connected to healthcare services, we don't know the answer to that. Another really interesting point from this, though, is that she was actually able to start adhering to antiretroviral treatment, which she hadn't before, and had actually fully suppressed her viral count at time of delivery. So now, take-home points. Medications are not generally recommended for management of stimulant use disorder in pregnancy, but there may still be a role for them, in particular in cases where the individual has not responded to standard treatments, in cases where those treatments are not available, or in cases where the person may not want to pursue psychosocial interventions. What I mean here by the point that treatment of comorbid disease can help guide choice of agent is that, for instance, if we have somebody who's using methamphetamines or cocaine and is also trying to quit smoking and may have some mental health concerns, then bupropion may be a good agent. Or if they're having a sleep disturbance and mood concerns, then mirtazapine may be an appropriate agent. Or if there's a history that's supportive of ADHD, then a long-acting amphetamine could be a good option. For clinical pearls, to summarize, comprehensive prenatal care, super important. Continuity management is great. We need lots more programs. Breastfeeding should be a risk benefit assessment. Breast milk's liquid gold. If the mother decides to breastfeed, then delaying by 100 hours from last use of unregulated stimulants is a possible approach to allow for full clearance of the drug from breast milk. Lastly, use of medications is not generally recommended, but they may still play a role. For selected resources, so I really like the Prenatal Services BC. It's like a very succinct document. And it doesn't just talk about stimulant use disorder in pregnancy, it talks about other substance use disorders in pregnancy. And I love it, it's very up to date. Also, the Race Line is a great resource where a person can talk to a prenatal addiction medicine specialist Monday through Friday. There's another article, this one's from 2015, not specific to stimulant use disorder, but talks about other substance use disorders in pregnancy, and it's very comprehensive. So I think it's another good one. And then lastly, there's this committee opinion by ACOG, And it's starting to get dated now, but I do see it cited a lot in the literature, which is why I decided to include it. I have a lot of references. Oh, and please take a moment to complete this survey, and I'm open for questions. Yay.
All right, thank you, Zach. That was a wonderful overview. I would be remiss, I'm just reminded, for those who aren't aware, this is an opportunity for me to mention that St. Paul's now has a perinatal substance use service, which has been alive now for about the last month or so. So if the opportunity arises, know that we actually have a dedicated service within the hospital for consultation on patients such as this one. But with that, I'll open the floor to questions for Zach. I'm looking online as well. I think there's something in the chat. I'll take the first stab at it while people are still gathering their thoughts. I'm curious. So I'm struck by the fact I think you've highlighted some really important considerations around kind of really perinatal considerations. But it seems like the treatment landscape in this population is kind of equally, I don't want to use the term bleak, but like there's not a tremendous amount of options here, and it looks pretty similar to non-perinatal populations. I am curious about whether there's any data on contingency management in this population related to durability of the effect. As many of you may know, contingency management is the gold standard for treatment in general populations, but it's not a particularly durable effect. Once the program ends, people tend to return to previous patterns. Curious, given that you could almost consider the pregnancy in the child itself to be almost a form of contingency, whether there's any data around durability of that effect here.
Yes, so like postpartum rebound effect is quite common. For that randomized trial I cited, I don't remember what the duration of the effect was, but I will be sure to send you that article.
Right. Perfect. Yes.
Hi, thank you so much for your presentation. I especially enjoyed the part talking about breastfeeding. I know you mentioned all the benefits of breastfeeding, but also it can be really hard, like things like handling medications, sort of half-life, BPS, which could be like stigmatizing for the patient. I'm wondering, like, when would you consider just perhaps formula for the patient because of breastfeeding? Like, if that's an easier way, then how? I guess how do you make that an option?
It's up to the mom.
Zach, can you repeat the question in the microphone for those who are on?
Oh, my apologies. The question was, at what point one would consider formula instead of breastfeeding for somebody with stimulant use disorder. And so the answer to that would be it depends on what the mom wants after you've counseled them on risks and benefits. It depends on what's practical for them, what they wish to do really ultimately. If they want to formula feed, then that's their call. And then there's another question here. It says, have you seen any naltrexone bupropion used with pregnant folks in Canada? Using that PO naltrexone being that long acting isn't available. Yeah, so that's one important point, and I forgot to mention it when I was talking. So we don't have Vivitrol in Canada. We don't have the injectable naltrexone. You can get a special authority for it, but it would still not be, we can't. Oh no, okay, we can't get Vivitrol in Canada. Not sure if oral naltrexone would work because it actually has a really short half-life, so it may not provide that same benefit. I don't know, because that study hasn't happened yet.
I'll just add to that, that in the new ASAM AAP guidelines from the US, they do suggest the use of oral naltrexone if injectable is not available as a reasonable alternative, but that's based purely on a hypothetical effect. It's not, there's not been any actual studies comparing it to the injectable formulation for treatment of this population. Nope, that was the one in chat. Any other questions for Dr. May? No? Okay, with that, I would like to thank you for a really in-depth overview of a really topical subject. Thank you all for attending. We are off next month. I think we're back in May for our last round of what's new in addiction medicine.
Fill out the survey.
And if you can please fill out the survey.
I feel like a music director.
No overheads for the whole hour. No alarms.
Oh, yeah. Thank you.